Acute otitis media. Key points. Diagnosis requires acute onset and an abnormal ear examination with signs of middle ear inflammation and middle ear effusion. Avoid the routine use of antibiotic treatment for acute otitis media. Background: acute otitis media, AOM, is a common problem in early childhood. 75% of children have at least one episode by school age. Peak age prevalence is 6 to 18 months. Causes of acute otitis media are often multifactorial. Exposure to cigarette smoke from household contacts is a known modifying factor. Assessment: history, recent onset ear pain, fever, loss of appetite, vomiting, lethargy, cochlear implant, immunocompromise. Examination: systemically unwell. Ear examination: signs of acute inflammation of the tympanic membrane, TM bulging, red, opaque TM. A red TM alone is not AOM. The most common cause is a viral upper respiratory tract infection. Otoscopic images of tympanic membranes, TM. Normal tympanic membrane. TM is translucent. The handle of the malleus is vertical. No erythema. Injected tympanic membrane. Pink/red TM. Often seen with fever, eustachian tube obstruction, or viral URTI. TM is transparent, there is no middle ear effusion. The handle of the malleus is well seen and is more horizontal. Bulging and red tympanic membrane in AOM. Loss of the TM landmarks, especially the handle of the malleus. TM is opaque, may be red from inflammation, white from pus in the middle ear. Otitis media with effusion, OM, glue ear. TM is retracted with prominence of the handle of the malleus, which is also drawn in / more horizontal. TM may be bulging or have an air fluid level. The TM yellow/amber appearance is consistent with fluid. Light reflex on otoscopic examination. Perforated tympanic membrane with otoroe. Otitis externa. Ear is tender to examine. Skin of the external ear canal is swollen and there can be thin pus. Management. In infants, especially and LT 6 months old, the diagnosis of AOM and OM can be inaccurate. Other diagnoses should be fully considered, see. Management may also differ for children from higher risk groups, such as those living in Aboriginal or Torres Strait Islander communities. See additional resources below. Investigations. There is no role for routine diagnostic investigation for AOM. Diagnostic imaging such as CT and MRI is usually only required in children with suspected intracranial complications. Treatment. Most cases of AOM in children resolve spontaneously and antibiotics are not recommended. Blank. As an adjunct, short-term use of topical analgesia e.g. 2% lignocaine, 1 to 2 drops applied to an intact tympanic membrane, may be effective for severe acute ear pain. Decongestants, antihistamines, and corticosteroids are not effective in AOM. Complications. Tympanic membrane perforation. AOM with TM perforation is common and results in otoroe and frequently, relief of pain. Otoroe due to TM perforation should be distinguished from otitis externa. Acute mastoiditis, AM. Acute mastoiditis, although rare, is the most common suppurative complication of AOM and may be associated with complications. The diagnosis of AM is based on post-auricular inflammatory signs, erythema, edema, tenderness, or fluctuance, a Protruding auricle often with external auditory canal edema and signs of AOM, see image below. Blank. Consult ENT as may require surgical treatment. Acute mastoiditis. Other complications. Other suppurative complications including intracranial spread of infection are rare. Facial nerve palsy secondary to AOM should be discussed with ENT. Long-term non-suppurative complications include atelectasis of the TM and cholesteatoma. Otitis media with effusion, OM. OM, previously termed serous otitis or glue ear, is fluid in the middle ear without signs and symptoms of infection, other than transient hearing impairment. The presence of a middle ear effusion is not a diagnostic sign of AOM, and effusion may not resolve for up to 12 weeks. Following AOM, antibiotics and ENT referral are not routinely required for OM, as the majority of cases occur after an episode of AOM and resolve spontaneously with no long-term effects on language, literacy, or cognitive development. Persistent effusion beyond 3 months should trigger a hearing assessment and ENT involvement/referral. Consider consultation with local pediatric team when children who are systemically unwell, neonates, children with signs of acute mastoiditis or who have a cochlear implant should be discussed with ENT. Consider transfer when children requiring care beyond the level of comfort of the local hospital. Consider discharge when no signs of complications.